Hi, I'm Dr. Heather Hirsch and welcome to my YouTube channel. In this video, I'm going to talk about 3 of the most common side effects that happen to women after starting hormone replacement therapy. The reason I wanted to do this video is number 1, to let women know that there are very commonly occurring side effects that happen when you start on HRT. And if you are prepared for them, you won't be as fearful if and when they happen. I also want to go through with you what those side effects may mean and how you can work with your clinician to make some adjustments to your hormone therapy. Because the truth is, if you can work through those side effects and get on the right dose, the right route, and the right formulation, you are going to feel so well and so confident about your HRT regimen. And that's what we're going to do in this video today. Hi, if you don't know me, my name is Dr. Heather Hirsch. I am the CEO of the Health by Heather Hirsch MD Collaborative, which is a private telemedicine practice. We see patients in over 25 states, and we're really clinical experts in providing care. Those visits also come with my 8-hour complimentary course, the Reclaiming Menopause Masterclass, as well as a community and Facebook group. But again, I want to make this video so that you can work where you are with your own clinician, and we're here to help you if you need to seek a second opinion or you want to go straight to expert care. The number 1 and most common side effect with hormone therapy is bleeding. It is not the scary things. In fact, I have lots and lots of videos about why hormone therapy is safe and effective, and even this video on how to get started on hormone therapy if you're totally new to this, but you stumbled upon this video and you kind of wanted to watch it anyways, or you've got an upcoming visit with your doctor. But bleeding truly is the most common side effect. First, why does bleeding happen? Well, it actually makes a lot of sense. So we're giving you low dose of estrogen to help stop all those receptors in the brain that are saying, where is the estrogen? And they are just sending these messages that are causing hot flashes, also known as vasomotor instability. They can cause the mood changes. They can cause the brain fog. They can also cause other symptoms in your body when estrogen's low, like heart palpitations. It can cause changes in the GI system. And there's many, many long-term benefits to hormone therapy as well. So when we're giving you estrogen, we want it to work in the brain and in the heart and in the bones, but not at the level of the uterus and the ovaries. But sometimes your uterus gets involved. We can't actually tell the estrogen, please don't go to the uterus. So when estrogen gets to the uterus does what it used to do when it had estrogen, which is build up that lining, reach a critical mass, and then shed, which is i.e. bleeding. So actually the number 1 reason for bleeding when you're starting on hormone therapy is the hormones. And oftentimes this can be easily resolved by fixing the hormone therapy dosage. So there's 2 main reasons or 2 main things that you can look to try to alter to stop this bleeding. The first would be lowering the dose of estrogen. And that makes sense. Estrogen is causing the uterine lining to be stimulated to build and then shed. So whatever dose of estrogen you're on, you could reduce that dose. Simultaneously, progesterone, which you should be taking if you have an intact uterus, is kind of the hormone that is holding that uterine lining together and keeping that uterine lining nice and stable. So another thing you could do is increase the progesterone. And actually, there's no reason you couldn't do both, decrease estrogen and increase progesterone. Some women actually will get bleeding if they're cycling the progesterone, meaning if they're taking it 12 days of the month and then stopping. Sometimes that stopping can actually cause a withdrawal bleed and basically just kind of shocks the lining into shedding. So sometimes taking the progesterone continuously can also help with that bleeding. But the use of hormone therapy is the most common reason for bleeding. It's so common, and there is so much physiologic reason why that bleeding within the first 6 months of starting hormone therapy or making a hormone therapy adjustment, which means changing the dose or the route or the formulation, that bleeding within the first 6 months does not need to be worked up. A lot of times I see patients getting rushed to ultrasounds and rushed to being biopsied when they've had bleeding within 4-6 weeks after starting hormone therapy, and it is so normal within the first 6 months. So for my patients, who are in that window and have bleeding, I first make adjustments to their dosages, and that usually stops the bleeding. And if so, I have no other reason or indication to continue on. So in summary, bleeding is the most common side effect when starting on hormone therapy. It's so common, in fact, that when it happens within the first 6 months of starting or adjusting, it is considered to be hormonal. Therefore, adjust the hormones. And you can do this by either decreasing the estrogen, increasing the progesterone, or doing both. All right, the second most common side effect when starting hormone therapy is breast tenderness. And the reason for this is very similar to why we get bleeding. Remember, we can't tell the estrogen not to go to our breast tissue. So breast tenderness is really common. And this can either be the breasts actually feel fuller, or they feel sore, like you don't want someone to hug you, or even the nipples can feel a little bit itchy or irritated. And usually it happens bilaterally. Now, many women, because of, fears of breast cancer or breast disease, are worried that it means something, and it actually just means that it's the hormone therapy and it's working, and maybe it's working a little bit too well. So the first thing to do, again, is adjust the hormones. Now, if a woman is taking estrogen and a progesterone, which she should be doing if she has an intact uterus, you want to make sure it is in fact the estrogen. Now, in my clinical experience, 80% of the time is the estrogen that's causing breast tenderness, but 20% of the time is actually the progesterone that's causing it. And so often what I do is sort of stop the offending hormone, one of them, not both of them. So for example, if I have a patient on a patch and progesterone, and she says, I'm having terrible breast tenderness, I'm thinking it's probably the estrogen. Let's go ahead and stop the estrogen patch for a few days and see if the breast tenderness goes away. If it does, and she continued to take the progesterone, then we know it was the estrogen and not the progesterone. Then what I would do is decrease the dose. So similar to the bleeding, we're gonna decrease the dose of estrogen. And usually I just typically half the dose of estrogen. You can also do this if you have a patch and you just wanna quickly do this before, if you're a clinician, before sending in a new dose, you can actually have the patient just cut that patch in half and see if that breast tenderness goes away. Now, the reason again to make sure it's the estrogen is about 20% of women is actually the progesterone that causes the tenderness. So if they've stopped the estrogen, which is 80% of the times the reason, and the breast tenderness did not budge or go away, then it's more likely that it's the progesterone. So then what I have them do is that experiment, but this time put the estrogen back on. I'm thinking, the patch or the gel or the oral, and stop the progesterone. And in that case, we'll find out that it's probably now the progesterone that is causing the breast tenderness. And there is progesterone receptors in breast tissue, just as there are estrogen receptors. So you just want to be sure you know which hormone is the offending agent. Now, if it is the progesterone, I have a whole video on progesterone intolerance. This means that we want to find a different way or route or formulation of progesterone because they all act a little differently. If you have a uterus, you must take progesterone to protect against uterine cancer from unopposed estrogen, i.e. estrogen without a progesterone. And so we have to find a new progesterone for you to decrease the breast tenderness. A couple of quick ideas could be actually placing an intrauterine device that's going to actually remove systemic progesterone entirely, because an IUD is going to give local progesterone to the uterus only, i.e. the breast won't feel it. Or you could try Duave, which is a combination of conjugated equine estrogens and beta-doxephene. Actually doesn't have progestin in it per se. It has a medication called beta-doxephene that protects the uterus. And there's lots more options. So if that is you fall into that sort of more rare category, I recommend checking out those videos on progesterone intolerance. Finally, the last thing that I see commonly is, hey doc, this just isn't working. And if hormone therapy isn't working, there's usually one of three reasons. It's either not the right dose, which is the most common. So we might need to increase the dose of that hormone therapy. And I say all the time, the motto is the lowest dose that works, not the lowest dose that doesn't work. Also, clinicians mistakenly believe that a higher dose is higher risk. That could not be farther from the truth. We need to use the dose that is going to give you therapeutic benefits. And different doses will cause different serum levels in different people. And that's why I have patients on every single dose of the patch, of the pills, of the gels, because it all depends on our different physiology and the bioavailability and how we metabolize those hormones. So typically it's the dose that's wrong. So we might want to increase the dose if it is just not working or not having any effect. Or if it's not the dose, it could be the route. So route means potentially you're on a transdermal because those are very, very popular, but for some reason it's not absorbing and you think you're not getting any, or we've changed the dose of that and it's still not working. It might be time to change the route. So either transdermal to oral, oral to transdermal. And yes, transdermals are very much favored, but oral can be very convenient, very, very safe for many, many women. And then lastly, it could be the formulation that needs to be changed. So there's conjugated equine estrogens, there's estradiol, that's what's considered bioidentical, all FDA approved. There's different formulations of progesterone, which I also just briefly discussed in this video. So there's our bioidentical micronized natural progesterone or prometrium, and there's also progestins. So there's lots of different formulations of hormone therapy, and that could be the reason your hormone therapy is not working as well. All right, so those are the biggest side effects that I see when women are starting on hormone replacement therapy. And I hope this video was really helpful to give you a heads up of what's to come, especially if you didn't get a long consultative visit with your doctor. In my telemedicine practice, we have hour-long visits, and trust me, even that is not long enough. If you look at my YouTube channel, I probably have hours upon hours upon hours of talking about hormone therapy. So there is just so much to learn. I also have a free masterclass. If you have not watched this, you totally should. I'm going to put the link to the free masterclass in the description below. I hope that you are really confident about your midlife and menopause journey. And again, I have a private telemedicine practice. If you want expert care, and if you're a clinician, I also have a course. And if you're not a clinician, I am so excited to be training clinicians on how to confidently prescribe and manage FDA-approved hormone replacement therapy. All right, guys, thank you so much for watching all the way to the end of this video. If you love this, please subscribe, hit that notification bell so you never miss a video, and I'll see you in next week's video. Bye, guys.